Hello, my name is Dr. Christopher John of Directional Non-Force Technique. The video you're about to see is about palpation and body marking in DNFT. Now in DNFT, this is a very, very important aspect of our type of chiropractic. In order to do the challenging to find out where the subluxations are and keep a record of what we have done, we must be able to identify all the vertebra, pelvis, extremities, cranials, and so forth. We need to do this in a way that is very accurate so that from visit to visit we know whether or not we're working on the thing that we did before or whether there's a new subluxation. So it is not good enough to know that we have on a prior visit worked in the mid-back and this time we're working on the lower lumbars. These things are nowhere near good enough in DNFT. We need to know whether we corrected lumbar number 3 or lumbar number 4, whether we corrected cervical 2 or cervical number 3, and all the various components of the direction of that structure. For this reason, DNFT has evolved to a very fine art and science. I should mention also at the beginning that it is absolutely imperative that a patient wear a patient gown, a gown that is open in the back so we have access to the spine. Anyone claiming to do DNFT without taking the patient out of street clothes and putting them in a gown cannot be said to even be doing DNFT because there's no way that we can accurately test, challenge, and correct through all these layers of clothing. So with all of this in mind, let's proceed to first of all show you the structures that we do mark up, the various things that we want to have as landmarks on the spine, and then we'll talk about the various techniques of palpating so that we develop accuracy with this. Now, as we begin to palpate and mark up this subject, one very important thing to notice is that we have here a Dutchman roll. This Dutchman roll is something that you need very much for the low back palpation. It should be placed under the subject, not right under the trochanter, where patients often would prefer it, but rather more so the center of the Dutchman roll is at the center of the crest. This is so that you get flexion in the lumbars so that it's assisting us with our palpation. Now, on any given palpation, you're going to be working either from the bottom up or the top down. Here we're going to be working from the bottom up. On the first day's initial visit palpation, I like to do full spine. So I'm going to palpate the PSS's, posterior superior iliac spine. This is one of the landmarks that is easy to palpate on anyone, regardless of body fat. So this is one of our key landmarks. I palpate it, and I palpate it down to the inferior aspect. Note that at the inferior aspect, I put a little hash mark here. We'll see the why of that in a little bit. Each side. I also go up and I palpate the top of the crest. I put a slash on each side of the top of the crest. So now I have to palpate my lumbar spinuses. So there's a couple ways to go. On someone who is easy to palpate and who you may know has normal anatomy, you may slide off the sacral base, slide off the sacrum onto the 5th lumbar spinous, and on her this is relatively easy. But now let us say you have a subject that perhaps is not so easy. In that case, you can put your hands on the top of the crest on each side. You're going to meet your thumbs in the middle, and right there you should be feeling the spinous process of lumbar number 4. Now there is some variance here. You may be on the spinous directly. You could possibly be a little bit below it, which would be the more common case, or if the subject happens to have extremely high crest, occasionally you may be on the interspace above it. But most of the time you will land up on the 4th interspace. And if I were to draw that out on her, it would be right here. And there it is. So knowing that that is the lumbar 4 spinous, I'm going to palpate for lumbar 5 and mark it off. Since I know this is the sacrum, I like to put a vertical line down the sacrum, knowing that S1 begins approximately there. Now, in the lumbar spine, it is a good idea to mark off the spinous process of each vertebra. And when you get to T12 right here, then you're going to put a cross. So we have lumbar 5, 4, 3, 2, 1, and a cross at T12. Now, on somebody that is young, has relatively low body fat, it becomes rather easy to just come along with your finger like this, palpate the interspace between the spinous processes. But on someone a little bit older who has thinning disc spaces, has arthritis, the bones are more or less growing toward one another, you may have to come in from the side, such as this. Such as this. Now I am feeling deeper into the spinous process, and it becomes a bit easier to palpate that little space. Come around on either side. Capture that spinous process. And another thing to remember, when you are palpating, you might tug the skin down like this, but if I were to mark that and I let go of the skin, that spot would move up. We should have the mark on the skin where the spinous process is when the skin is not being tugged. So if you must tug on the skin to get somewhere, mark it, let the skin go, and then put your mark. Now, something you would not normally do on a palpation, which I will do for the sake of this video, is draw a little dotted line here between the crest so that you can see how it pretty much goes through that lumbar four spinous. Now let's move up into the thoracic spine here. We're going to mark off, we're not going to mark off every vertebra here. I'm going to palpate T11, T10, T9, and when I get up to T8, then I'm going to put a horizontal slash. So that's our next landmark, T8. Then we go to T7, 6, 5, 4, another mark on T4. And then finally, 3, 2. Now, if your subject happens to have her neck a little bit in extension or straight, ask the subject to tuck her chin down in toward the chest. This makes it much easier to palpate thoracic 3, 2, and 1. And when you palpate thoracic 1, you're going to put a cross on that in the same way that you did on T12. Go right above it and put a little horizontal slash on C7. Then I slide off C7, and in a way that only becomes feasible or possible if the head is in flexion, I can palpate with the very tip of my finger there, actually what I call a fingernail palpation, the spinous of cervical number 6. So we get C6, and then I put another mark on C5. Finally, I palpate the spinous of cervical 2. Note I didn't have to really walk my way up there because the cervical 2 has a very prominent spinous process. So I merely put a mark like this, and this is our body marking. A horizontal slash on cervical 2 and 5 and 7, a dot on 6, and a cross at T1. Now let's go back down to thoracic 12. And let's talk about how we can be sure that we're in the right place in different parts of the body. The cervicothoracic area in the neck in particular will require a little bit of explanation because these are a bit more difficult to palpate on most people. When you get up to T12, by the way that we palpate the lumbars, you should be pretty confident that you are in the right place. It is possible, however, to capture that spinous process and begin to try to palpate the 12th rib. Now, on this particular subject, it is especially easy to palpate. I just go deep here, I come up, and you can actually probably see my finger go right over it. That is the 12th rib. Now, if I found that rib way down here, or I did not contact it until it was way up here, I might be suspicious of my accuracy on T12. We're going to at first be looking at the relationship between the location of the spinous process of a vertebra and its respective transverse process. Now, this varies throughout the thoracic spine. At the lower part here at T12, the distance between the spinous and the transverse is approximately 1 vertebral height. As you go up to T1, the very top of the thoracic spine, even though the distances are less, the relationship is pretty much the same. The distance between the spinous process and transverse, about 1 body height. But all throughout, as you go down, you're going to find a variance. Now, right about at T7 or T8, we have the biggest change. Let me count down to that. 1, 2, 3, 4, 5, 6, 7, 8. Here we are at T8. And here is the spinous, and here is the transverse. Now, as you can see, it is about approximately 1.5 spinuses above. This particular plastic spine has a situation here in which that's sort of hard to see because of the way that the spinous processes have been changed with time. Whatever mold was made of the bones here, take a look at the angle of these spinuses versus this or versus this. So this is 7 and 8 thoracic spinuses. So what we're going to do then, though, is take a look at the fact that still it's about 1.5 approximately spinuses above. While we're on that transverse, let's take note of the fact that when you palpate a transverse, you must be far enough from the center to actually be on the transverse, because if you get too close, you will be palpating this lamina here. It is okay to palpate that. You will be able to palpate it. But if you do, you may think that that transverse is much lower than it actually is. See, the transverse is up here, whereas you'll be palpating the lamina down here. So be sure that you're far enough out that you're actually palpating the transverse instead of the lamina. You will then discover that this transverse, in fact, is 1.5 spinuses above. Notice, additionally, in the thoracic spine, as we will be palpating, marking off, and challenging and correcting the discs, that we simply are getting in between the TPs here. This is the intervertebral foramen in which you aim a negative finger to challenge for a disc, and you'll be coming with your plexor to correct it. There is so little space available here that you, in essence, could say that the access to the intervertebral foramen is literally in between the transverses. Of course, the ribs are also going to guide you here. So note that there's not a whole lot of room to play with. You should be very confident of your palpation. It will feel as though you have 2 speed bumps here, and you're palpating a speed bump, a little valley, and then another speed bump. This is how you palpate your IVF. So now we're going to mark off the transverse processes that correspond, in this case, to thoracics number 4 through 8. What I like to do is capture the spinous process between my fingers. And actually, before I do that, let's mark off all the spinuses so we can see what we're doing here. Now remember, we would expect to find this transverse approximately 1 to 1.5 spinuses above the spinous of T8. So we come up here and we begin to do our palpation. We remember that we must be far enough away from the midline so that we are not palpating the lamina. It's okay to palpate the lamina. I can feel it right there, but we really want to get on the transverse, which is more right here. It's very easy for me right now to palpate that transverse. So I mark it, and I'm going to connect it to that spinous. Same thing on 7. Note that it's a little bit more, let's say 1 1/3 spinuses above. Let's jump up to thoracic 4, because with 4, you should find its transverse approximately the spinous above. Let's see. There. And then we'll just fill in the missing dots here. The transverse of 5 and the transverse of 6. So notice now that there's a little bit of a gradual change of the distance between the spinous and the transverse. We're almost at 1.5 right here at T8. We're about just 1 or so up here at T4, and it just is gradual change in between. How about the ribs? Let's mark off some ribs. 8, 7, 6, and 5. Now, you don't have to, of course, mark off someone like this when you're actually doing a patient visit. However, if you do discover a subluxation, let us say that subluxation is thoracic number 7. What I like to do is I do have the spinous marked off. I actually do this and put a little hash mark on the side that has gone anterior. So now when I'm doing my actual adjusting, it is very helpful because I see the level that it's at, and I come up here and I take tissue pull to the transverse like this, to the transverse, and like so. And also when I come around to correct the laterality of the vertebra, then here's my rib. I can slide off the angle of the rib onto the lateral aspect of the transverse process like this, and to correct the laterality. Now, where do we find the point at which we come in for our analysis and correction of the intervertebral disc? Well, it turns out that, of course, it's in between the transverse processes here in the thoracics. So if I palpate in between the TPs, it's like going over two speed bumps, and in between the little valley, I go right in there. That is the IVF. So I'm putting some dots here where the intervertebral foramen is as we go along. Again, the value of this, you don't have to mark these in. You might want to at first, though, as you're beginning DNFT, because then you can simply come in. Here's our plexor, and to correct the disc. Now we'll take a look at the lumbar spine and some of the things we need to note about it. First of all, when you palpate spinuses, that's a relatively simple thing to do because they're so prominent and they're so widely spaced. But now when we palpate for the transverses, what are we really palpating? Actually, you could say that we're palpating the mammillary process. Here's the mammillary, here's the transverse. But if you look from the side, you can see that the mammillary is more toward the surface of the skin than is the transverse. And given the musculature that you have in the low back, in essence, what you are really going to be doing is palpating both, but you're probably going to be more aware of the palpation of the mammillary process. Relatively simple, however, because if you note, the mammillary transverse of the vertebra is approximately at the spinous of its upstairs neighbor. So the spinous of 4, mammillary of 4 is about approximately at the level of the spinous of 3. Another thing worth noting, very important in fact, is the distance away from the midline of the intervertebral foramen, or I should say the access to the intervertebral foramen, because up here at lumbar 1, it's only a relatively narrow distance, but if I went down here, you could see that L5 is much wider. So when you do your palpating and you aim your negative finger, and eventually when you come in with your plexor that will be coming in here like this, you need to be far enough out so that you get in there. So not so far out here with lumbar 1, but you need to be, it appears to be over an inch away from the midline at L5 in order to get into this space. Let's take a real close-up look of this space here, in fact, at our 5th lumbar. And it is a little bit distorted by this mechanical model because of the way it's screwed in. It makes the situation appear even a little worse than it is. But notice that we have this triangular space here, bordered by the crest here, transverse mammillary here, and the sacrum down here. So we must become extremely proficient at palpating this. You can slide off the crest like this, and you'll find yourself going into a space right here. And it'll be like a little dimple, a little, as they would say in Hawaii, a little puka. And that is where you aim your finger, in this case, down at an angle about 10-15 degrees. It's just required at this point and nowhere else. And then when you correct it with your plexor, which I will use my finger to pantomime, that would be coming in just like this. Now, as we go up here, let's say to lumbar number 3. Where is the disc? Now, in the thoracics, we say it's in between the transverses. If we applied that rule here, now we would be a little bit off, wouldn't we? Notice how the disc is actually more down toward the transverse below than it is actually in between. This is not a consideration higher up in the spine, but it would be here in the lumbars because things are so big and open and exposed, so that when we correct that disc here, in this case lumbar number 3, we're then going to want to palpate for this transverse, slide off of it. You'll slide off of it into a dimple, and then, see, you'll be going in toward the disc, but notice, I'm just over the transverse. I'm not up here, and I am here. The final thing to note in the lumbar spine is the sacrum. Now, here we have these sacral, what we call foramen, these holes. And you might want to mark them off with a marking pen. Generally, we find if one is subluxated, they're all subluxated, and we would aim a negative finger. Here, I must say, is one area where this plastic model falls down a bit, because typically you would glide medial over the PSS and you would come up a bit. This model makes it look like you're not going very much above, but I believe on a live subject you would come a little bit higher up to palpate that first sacral foramen, second sacral foramen, third, fourth, and the textbooks say sometimes fifth. So you just simply mark those off and challenge them, and you'll correct them with a plexor going straight in there. Now we're going to turn our attention to the lumbar spine to discuss some of the structures associated with the spinuses that we have already drawn out here. Now, in the case of the lumbars, we're looking to take our contact for correction on the transverse and actually the mammillary, because the transverse is somewhat deep spatially to the mammillary, and they're at the same level. So when we do our correction, for example, on a lumbar to get rid of the rotation of the tilt, we need to know where the mammillary process is. Well, it's just about at the spinous above. It's rather simple in the lumbar spine. It's a little bit, you have to go a little bit deeper to do this palpation, but I can feel it on her right here. So I'm going to connect some transverse mammillaries to their respective spinous process here. Very easy on her to do all these palpations, but you must become proficient to the point when you get somebody who's either thickly muscled or has a lot of fat, that you know how to find these things based upon where they should be. And then you go deep right at that spot and you'll be able to find it. Now, obviously we have no ribs down here. How about the IVFs? Now this is a very important palpation here, one of the most important that you will do. I'm going to more or less draw a line along the crest here. Now remember, from looking at the skeleton, we have this little tiny space here bordered by the crest, bordered by the mammillary transverse right here, and of course the lamina over here. So if I just slide right off the crest, there is a little space there into which we're going to aim a negative finger for analysis and also go in with our plexor to correct. But one important point about the lumbar spine, as we mentioned, is that you have to be far enough away from the midline, especially at L5, to clear these bony structures. You do not want to be thrusting, obviously, into the mammillary process. So you must be, this looks to me to be about 1.25 inches, and some people maybe 1.5 inches or more. Whereas up here in L1, you'll wind up being a little bit closer. Now, something of consideration in the lumbar spine that we don't worry about so much in thoracics is if you take the distance between these TPs here, whereas in thoracics, the IVF is exactly in between. Here in the lumbars, if you look at your skeleton, you'll find that it's only about 1/3 of the way up. In other words, right here, here. Slide off into the little puka. It's just simply a function of the slightly different anatomy. So here are the IVFs of 5, 4, 3, 2, and 1 in the lumbar spine. Suppose we were to do an analysis or a correction for a lateral disc. Just remember, we're simply following the plane line of the disc over here. Plane line of the disc. Now we're going to point out that there is an area in which you will be challenging and correcting for the lateral discs. The reason why I can say there's an area, because when we do this, we don't want to be going through a bony structure such as a rib. We want to be going in between them. And because we must go in between them, we have to jog back and forth a little bit in order to find this open space. So therefore, you're close enough to coming in straight lateral as long as you're within these boundaries. So let me draw these lines that will define where you can come in. This is one, and I would say here is the other. So in other words, all along here, you may, I'll give you an example. Here is the IVF of thoracic number 8. Now if you go straight over here, in between here and here is where you can aim a finger to analyze and also correct. Now if I'm right here, I'm directly on a rib, but if I move over here, I'm in between ribs. So I'll aim a negative finger to challenge, and then of course the correction would be the modified thumbnail in between the ribs going straight in. Now down in the lumbar spine, it is actually a little bit more easy than the thoracic spine, at least for most of these. Let us take the example of the lumbar 3 vertebra. Here I palpate and I mark off my IVF. And as you can see, we've cleared the crest here. We want to be somewhere in here. And actually, when you do the correction, you can get in pretty deep. You're going to be going in this spot straight toward center of the disc like that. But now, what happens on some people on 4 and for everyone on 5 when you want to analyze and correct the lateral aspect of the disc? Well, where's the IVF? We know that it's right here. So if we go lateral now, straight along in that plane, here's the crest. So now, believe it or not, we're going to be analyzing through the crest like this, and our correction will be going through it. So you're going to be putting an impulse of energy like this, straight toward the disc of L5, and it will work. It will work. When you get up to 1 and 2, be careful of this 12th rib now that we have, and the 11th ribs that we have to contend with. So you now do have to be in between the ribs here. With your mid and especially the upper thoracics, when we consider what we must do to analyze and correct the lateral disc, now we run to a situation where we must actually go through the scapula, generally with the 7th thoracic and then above. Let's take, for example, T5. Here's T5, transverse, transverse, IVF. Very easy to palpate. You take that like this, and now you're going to be going through the scapula with a negative finger to analyze the laterality of the disc, and to correct it, you'll be coming with your thumb like this. There you'll find there'll be a very tender point. Now, even though this particular video is not intended to be a review of correction, still the palpation interweaves very intimately with it, because obviously you must know these things in order to achieve your correction. So again, the palpation of these transverses, knowing where they are in relation to the spinous, marking off that IVF, and coming straight over here for example, the correction on the lateral aspect of T5. Now we are going to consider the cervicothoracic and cervical spines. I want you to note that in the cervicothoracic spine, things are certainly smaller in dimension, closer to one another, and it becomes quite important that we really know that we're on T1 or that we're on C7. Of course, the fact that the rib comes around and articulates with this facet at the TP of T1, that's a very good clue as to whether or not we're in the right place. So you just palpate the rib. If you have trouble from the posterior, palpate from the anterior, bring your finger and pinch it like that, slide over, and it should be going right into the TP like this. C7, typically the prominens, unless you have a loss of cervical curve or a reversal of cervical curve, in which case it may fool you, and the C6, normally pretty sunken, then may appear to be so prominent as to make you, to trick you into thinking that it's C7 instead of actually C6. So typically you would have the patient's head in forward flexion, you glide off of the spinous, for most people prominent, of C7, onto C6. C5 is typically at the crease of the neck, but our main landmark here would be the cervical to spinous. Even in an obese person, thickly muscled person, you certainly can palpate cervical number 2. Up here in the occipital condyles, this is not something we body mark, but we should be aware, right here in the center is the foramen magnum. Now, as we go over, notice that there's a sort of ridge right here. In the anatomy books, I have not seen a name for it, so it's a ridge to which muscles are attached. I now refer to it as the ridge of Van Rumpt. This is where we would challenge superior and anterior for your condyle rotation and tilt. And also, when you correct the laterality, see, you would not come in from the mastoid, which would be over here, but rather you would be coming in right toward that ridge of Van Rumpt here. You'd be grabbing here so you wouldn't slip, but you would be right there. As far as the atlas is concerned, this posterior arch, this has come apart, I'm afraid, a little on this model here, but this posterior arch is not palpable on some people and yet clearly palpable on others. But to do your challenge for the anterior mass, you simply slide off of the occiput down onto it. You know that the C2 spinous is here, that you can easily palpate, so it's obviously be in between the two. So you just go right into it and you challenge to the anterior to see if it is that way, and of course, not too hard to get onto the lateral aspects of the transverse here to challenge for the laterality. Now we'll turn our attention to the cervicothoracic region, an area where Dr. Van Rump used to say that most people mispalpated. And even for those of us that are veterans, it is easy to make an occasional error up here. Why would it be easy to make an error? Well, several reasons. One, the structures are smaller, the distances between things are less. Secondly, there are variations in the curves. If you, for example, a normal cervical lordotic curve would result for most people in C7 being prominent and T1 being easily palpable. However, if a person had an auto accident or for other reasons had a straightened or even reversed cervical curve, now you may find this cervical 6, normally very difficult to palpate, being so prominent as to fool you into thinking that it is C7. Another reason could be if you have a person, perhaps one who lifts weights, and their trapezius muscle is so thickly muscled that it's much higher. So now you're on T1, but instead of looking normal as we have here, with so much trapezius above it, you might think that T1 is too low. So these are the various considerations we have. How do we solve it? A couple of ways. First of all, be sure that you have a table in which either the headpiece tilts down or at least the opening is such that the patient can tuck their head down. So I will ask the patient to tuck her chin down. Now she actually already has it tucked down a little bit, and it makes it very easy for me. With tucking her chin down the way she's just done, she has made it very easy for me to do this palpation on cervical 6, where I put my dot. How about cervical 5? She's very young, but as a person gains any number of years, you will find that the wrinkles or the crease on the neck is a very good indicator of cervical number 5. Unless, of course, the patient is so obese that they have more than one set of wrinkles, and then, of course, that's a different story. But for almost 95% of the people, this is a very good indicator. So you're expecting C7 to be prominens. You're expecting to find a crease at the cervical number 5. One thing you can palpate on just about anyone, no matter who they are, is this cervical number 2 spinous right here. That's easy. You just go off of the occiput. Most people don't have so prominent an arch of the atlas that you would mistake that for being cervical 2. So you're just going to slide down over that C1 arch, which you may not even palpate at all, and then you'll find this very prominent cervical 2 spinous. You don't have to mark off, obviously, 3 and 4. Now, she happens to be a subject so easy that you can quite easily palpate cervical 3 and cervical 4, and here we have 5. Now we're going to take a look at what we need to do with some other structures on C7 and T1. First of all, an additional verification for the fact that we're on T1 is capture the spinous between your fingers and palpate for the first rib. Again, on this subject, everything is so easy, but I can palpate her first rib here. It is coming around from the anterior, and obviously I'm in the right place, because if we thought that was T1, the rib would have to be way up here, which it is not. So again, on this side also, if I just sketch out the first rib, notice how it validates my conclusion that that is T1. How about our intervertebral foramen? In this area, this is one of the trickier palpations you will do, and also one of the most critical. I capture the T1 spinous between my fingers, and with a fingernail palpation, I come over here and I can feel that there's a little indentation, again, between these now tinier speed bumps, so to speak. And notice that if this is the level of the spinous, it is very close to it. It's not so high up. It is right there. How about C7? You will find in C7 that is actually right next to spinous process right there. Now, these are extremely important. Remember now that we have this new plexor, we call it the interlaminator. It has a flathead screwdriver sort of end on it, and this makes it easy to come in for our correction. So again, I've got the spinous. I would come in with my interlaminator like this, and look how nicely it goes in. This is what you will do to help many, many patients with their shoulder, their arm, numbness and tingling, and even cervical sorts of problems, because the C7 and T1 discs are something that we in DNFT are correcting and no one else is. And this is the main source of the nerve interference for symptoms down the shoulder, down the arm, and so it becomes very important. While we're here, let me also show you that it is rather tricky for any of us to correct the lateral component. I prefer to use a modified thumbnail contact. I go over here and look at this. Unfortunately, I have to deal with the fact that the rib is coming around here. So I simply do the best I can. I get as deep as I can, like so, and like that. On C7, I prefer to do it with the patient prone, but it is one that you could also do supine. This is a little bit easier in terms of the rib being in the way. It's not in the way, but notice how my thumb is right in here for the correction for the lateral disc on C7. Now we will take a look at the cervical spine, but this time from the anterior, because we want to have an idea in our mind of what we're looking for when we begin our palpation. We like to, let's say we have a subluxation at cervical 3. It does not show the mastoids here. However, typically we would get on the mastoid, slide off, and onto the lateral aspect of the atlas here. Now note how much wide or how much more lateral the structure of the transverse of the atlas is as opposed to cervical 2. So if you can palpate this and you just go down, your fingers will glide medial to the transverse of C2, and then you literally can walk your way down 3, 4, 5, 6, and notice how 7 though comes further out again. So at first we had cervical 2 being, atlas being more lateral, and we go down, and then finally when we hit 7, once again, it takes us out a little bit more lateral yet. Now, when we do our actual thrust, let us say we went C1, C2, C3. I'm palpating the lateral transverse of C3. I mark it, and I come across with my thumb in such a way that my thumb now covers the body. As you can see, pretty close toward the center. I've pushed the trachea out of the way, and yet this part of my thumb here is lying across the transverse. This proves that I can both get rid of the anterior mass plus the rotation tilt. When I angle my thumb like this, I'm getting both the anterior mass rotation tilt of C3. And then I would just go back to the lateral aspects of the C3 transverse in order to get my laterality component corrected. What about discs? Well, typically we're going to be dealing between C2 and C6 with anterolateral discs that are only below the involved vertebra. So let's again go down here. I'll take it on this side this time. C1, C2, let's say we were doing C2. And let us say we've already corrected the rotation tilt and mass laterality. So now I want to get the disc. With my fingernail, as you can see here, I actually palpate the space in between C2 and C3. I hold that. I come around with my thumb. And now my thumb is actually across the disc right here. Now I have noticed some people are going too lateral, too far out here. This is more of it, when you're over here, this is more getting the bone, whereas here is getting the disc. So you want your thumb to lie far enough around. I'll show from this side, it might be better. Right here. So now I'm getting the disc. And I think because of the fact we do it this way now, we no longer have to worry about anterocentral discs, because any straight anterior anterocentral component of that disc, I believe, is automatically corrected by the way that we now more correctly do the anterolateral disc. And this, you'll do this all the way down to and including C7. Remember that the anterolateral disc of T1, you go in below, underneath the first rib here. And you'll actually be doing it with a modified thumb. This, of course, will be in the section and the tape on correction of this part of the spine. Now we're going to talk about the palpation of the cervical spine with the patient supine. This is what you would be doing is preparation to the adjustment. I like to palpate the mastoid processes here, and as I slide off the mastoid, I am on the lateral aspect of the atlas. Now, if I go off the atlas, I slide more medial because the cervical to transverse does not go as far lateral as the atlas does. So you should be able to easily palpate mastoid, atlas, C2. Now when I say easily, I mean on a subject like this. What would make it not easy? If you had somebody with musculature right here, very tight, and just nodules of the muscle and the soft tissue that have built up over time. Still, you can palpate the mastoid, atlas, C2, and then C3. Now let us say I was doing a cervical 3 adjustment. I mark that cervical 3 with my finger. I make sure the subject's chin is high enough up, and I come in with my thumb. I am now have my thumb right where it should be. I'm at a 45-degree angle. Again, this section isn't about adjusting, but it does show you how you need to use the palpation to do accurate and correct adjusting. Let us go a little bit further down. Let's say I'm concerned with, let's say, cervical 6. Remember, at the base of the cervical spine, 7 is very prominent and goes further out. You can probably even see my fingers as I go from 7 to 6 go medial. They go medial. I hold my finger on C6. This is the technique throughout the cervical spine. Palpate that transverse. Hold your finger on it. Come in. You can actually feel on many people the body with your thumb. I am now set up to adjust cervical 6. Had it gone lateral left, anterior, and superior left. If I'm adjusting the lateral aspects of the subluxation, again, C1, 2, 3. I come in with my thumb like this, and straight through, straight through. What about palpating the cervical discs? Okay, now it's similar, but yet just a little different. I palpate 1, 2, 3. Now, the very tip of my fingernail there is in between the transverses of 3 and 4. I can actually feel that quite easily. If I hold that and I come over here with my thumb, I can wiggle my thumb and feel that I am at the intervertebral disc space between C3 and C4. And since in the neck we always are correcting the disc below the vertebra, I have a broad thumb contact and I'm more medial. Note the difference between the disc adjustment and the correction of the body. If you are a student, you need to practice this palpation frequently while you're in school. Of course, as a doctor, you should be performing this palpation on every patient that comes in. Now, on follow-up visits, you may or may not be involved with full spine palpation. I certainly think you should at least get the landmarks of T12, T8, T4, T1, C7, and so forth. Be sure that you do use gowns. You must have access to the spine. Don't be led into thinking that you can do this sort of work while the patient is in street clothes. You certainly must have access to the spine. And this palpation tape is also not necessarily meant to take the place of a seminar. It is intended to supplement a seminar for your work at home or in the field after the seminar. So you're encouraged to come to the DNFT seminars as often as you can, because in the groups we practice our palpation and generally find anomalies and variations on our different subjects that are very enlightening. My best to you in your DNFT practice.